We want to thank the committee for allowing us to present our work, a pilot evaluation of focused ultrasound ablation and focused ultrasound ablation plus PD-1 antibody blockade in advanced solid tumors. We have the following disclosures, and in addition, we received support from the Focused Ultrasound Foundation for this clinical trial. Despite success of systemic immunotherapy, the majority of patients still do not respond to this treatment. Cancers are capable of disabling and evading the immune system. There is preclinical data to support focused ultrasound ablation benefit in several malignancies. This works through direct ablation of the tumor, but also has a positive effect on the tumor microenvironment, which has the potential not only to enhance the immunologic control at the site of treatment, but also at malignancies beyond the site of direct ablation. When we ablate the tumor, we create a primary zone with a high heat and ablation zone. But there's a secondary zone around this, which has a lower heat stress, slower apoptosis, and creates immunological changes that facilitate control of the tumor. We propose partial ablation of metastatic cancer deposits will enhance tumor antigen presentation and T-cell infiltration. Our study population is in patients with advanced solid tumors that have measurable disease and regional metastasis. One or more metastases are accessible to focused ultrasound and biopsy. We anticipated that most of these metastases would be in the dermis, subcutaneous, or nodal metastasis. Patients present with either progressive disease after standard of care or patients who are not eligible for standard of care. We also will enroll patients who've had stable disease after 12 weeks of PD-1 antibody therapy and therefore have a low chance of response beyond that. Additional clinical trial criteria apply. The trial regimen appears here to be a little complex, but I'll summarize it, that there are two primary regimens. Patients who present who are already on PD-1 blockade or eligible for PD-1 blockade can enroll and be treated with focused ultrasound ablation at the tumor site. We also allow for patients who do not qualify for PD-1 blockade to enroll for focused ultrasound ablation alone without systemic therapy. Either of these cohorts can then go on to a secondary regimen, which we expect only in a very small subset of patients. And in that regimen, we will combine the treatments already discussed with topical imiquimod, which is a toll-like receptor agonist. The primary endpoints for this study are safety, to assess the safety and toxicity of focused ultrasound administered alone or in combination with PD-1 antibody blockade. We will also be evaluating the immunologic effects. We'll estimate the proportion of patients who have an increased CD8 T-cell infiltration after treatment with focused ultrasound in their metastasis. Secondary endpoints will include other immunological endpoints to estimate the proportion of patients with increased CD8 T-cell infiltration after spot focused ultrasound in untreated metastasis when these are available for assessment. Exploratory endpoints include the clinical response to the primary regimens discussed, in addition to additional immunological response, looking at cellular and structural changes in the tumor microenvironment, and the changes in the induction of circulating T-cell responses to shared and mutated tumor antigens. We will also look at the clinical response in the small subset of people who received the imiquimod. Our trial is currently open and to enrollment and was initiated on November 21st, 2019. So far, we've enrolled 2 participants. Both of these were in the regimen 1B, which is the focused ultrasound alone treatment. The first patient had metastatic colon cancer to a deposit in the left groin. The second patient had a metastatic thyroid cancer with treatment to a metastatic deposit in a right axillary lymph node. Treatments were planned over a 5 to 10 millimeter diameter area. The diameter of the treatment area depends on the size of the lesion. With our goal to activate the secondary immunological zone, we aim to treat 33% of the estimated tumor volume, or 1 cubic centimeter, whichever of which is smaller. We delivered a pulse to the targeted area and saw echogenic foci at the site of ablation. Biopsies were performed and used ultrasound to target the site of the tumor, which was not the target for the ultrasound ablation, so we could capture the secondary zone. In conclusion, this is a clinical trial which is currently in progress, for which 2 of 32 participants have undergone focused ultrasound ablation without immediate complication, supporting the ongoing enrollment of participants with accessible metastatic tumor deposits for focused ultrasound ablation of advanced solid malignancy. We'd like to thank our collaborators and our research team and the support of the Focus Ultrasound Foundation.